So what part of the ultrasound probe should be high-level disinfected? Well, we have the probe, the insertion shaft, we have the probe handle, we have the probe cable, which then leads to a plug socket, obviously, to provide electricity for the probe. Here is the Spaulding classification. This has been used now for decades. It's widely accepted around the world. It looks at the risk of infection based on how a medical device is used. And we have three different categories. We have non-critical under the Spaulding classification. This would be that the device, including a probe, contacts only intact skin, and the risk of cross-transmission is low. Then we have semi-critical. A probe contacts non-intact skin or a mucous membrane, and the risk of cross-infection is considered medium. Finally, we have critical. A probe contacts sterile tissue or the bloodstream, and the risk of cross-infection is high. Now, for semi-critical and critical items, we would either use sterilization, or if the device cannot be sterilized, we would use high-level disinfection. Well, let's turn now and look at the probe itself. What part of the ultrasound probe is classified as semi-critical should be high-level disinfected? Again, under the Spaulding classification, the area that comes in contact with the patient's procedure site, as you can see on the left, should be high-level disinfected. And the risk of, on the right, on the left, the risk of contamination due to damaged condoms is always present. So even if the probe has a condom, because condoms may be intrinsically with holes or may fail, we would still do high-level disinfection. We do recommend the use of condoms, but that doesn't mean that you can change the disinfection method. On the right, where the probe handle is that you're touching and which joins the cables, there is a risk of contamination through contaminated hands or gloves if you touch either the mucous membrane of the patient or the probe that's inserted itself. So then areas for high-level disinfection include the probe tip, the probe shaft, the probe handle, and the section of cable that might be contacted by the gloved hands. Okay, let's turn now to the part of the probe should ideally be high-level disinfected using evidence-based research, which eliminates guesswork. So here's some of the data based on what I've already told you. 13% of covers have tears. Pre- and post-transvaginal ultrasound examinations have demonstrated this. Before disinfection, approximately 44% of transvaginal probes had presence of bacterial contamination after the probe sheath was removed. That is, in removing the probe sheath, either the hands of the provider or the outside of the probe comes into contact with the area that needs to be high-level disinfected. This is similar to another study that found that 48% of surface probes tested positive for microbial contamination, that is, bacteria, fungi, or viruses. Let's turn now to the probe handle. 80% of probe handles had residual pathogens, including multi-drug resistant organisms such as MRSA. 62% of transducer cables showed microbial contamination, particularly in the area right near where it's handled. A meta-analysis found procedures using low-level disinfection wipes, contamination remained in approximately 13% for pathogenic bacteria and 1% for pathogenic bacteria on endocavity probes. Research shows that probes contaminated despite probe covers and low-level disinfection. There are multiple studies in the literature. One study from Hong Kong showed 7.5% were positive for human papillomavirus. Studies from France, two different studies, showed 3.5% and 2.8% HPV positivity after probe covers and low-level disinfection. Study from Spain showed approximately 6% HPV positivity, and another study from France was approximately 15%.